I'm Dr. Carsten Niemann, a hematologist in Copenhagen, Denmark. I'm chairing the Nordic CLL study group, and my research group focuses on data-driven hematology and development of clinical trials, mainly within CLL, but also running a lab focusing on minimal residual disease testing in mantle cell lymphoma and CLL. Looking at CLL for the last 14, 15 years, we tend to forget that it was in 2010 that the first publication ever showed improved overall survival for any clinical trial, randomized clinical trial data. And CLL, that was adding rituximab to a chemotherapy backbone of fludarabine cyclophosphamide. And then fast forward to today, having multiple different clinical trials reading out with targeted agents, combinations of targeted agents, providing improved overall survival and improved progression-free survival as compared to chemoimmunotherapy, and we're moving towards only using targeted agents. So that raises the question now, how do we find the best possible treatment option for our patients? How do we find the balance between efficacy and toxicity? How do we define the optimal length of treatment for different patient populations? So a very luxury position, both from a clinician perspective and patient perspective, but we need to put a lot of efforts into defining what is the right treatment for the right patient at the right time point. So the GLOW trial aimed to look at the patient population where we actually have most patients with CLL, meaning elderly or frail patients with comorbidity. And we tested if a new targeted combination of ibrutinib venetoclax would be superior to chlorambucil obinutuzumab. The same patient population was treated in the CLL 14 trial, testing venetoclax obinutuzumab towards the same backbone of chlorambucil obinutuzumab. But remember that we have the different treatment length. The chemoimmunotherapy is only 6 cycles, whereas it's 13 or 14 cycles or 15 cycles with a targeted agent combination. And what we wanted to look at was both the efficacy for this patient population. We already know from previous publications and presentations that venetoclax ibrutinib combination is superior both for progression-free survival and overall survival. But we do not know yet, and that's what we're going to look at this ASH meeting, whether the toxicity profile is different for venetoclax ibrutinib as compared to chlorambucil obinutuzumab, and in particular whether the toxicity-free, progression-free survival would actually be improved for the patients treated with ibrutinib venetoclax as compared to the chemoimmunotherapy group. We're looking at two things here in the trial. The already presented shorter time outcome in terms of progression-free survival and overall survival was sustained now with a longer follow-up. So we still see the superior progression-free survival and overall survival with ibrutinib venetoclax as compared to chlorambucil obinutuzumab for these elderly comorbid patients. Second, we now made a new analysis looking at toxicity-free, and here toxicity was defined as grade 3 or above adverse events. So toxicity-free, progression-free survival, that's essentially taking away the progression-free survival time where the patient do experience toxicity, significant toxicity. And doing that, we now see that patients on average have 20-month longer toxicity-free, progression-free survival with ibrutinib venetoclax as compared to chlorambucil obinutuzumab. Thus, we can conclude that despite the longer treatment time on ibrutinib venetoclax, the toxicity does not outweigh the better performance, the better efficacy. And that's really important from a patient perspective, because we know from patient group interviews that patients actually focus on the time outside of hospital without toxicity. That's what improves their quality of life. And we'll see this as also very interesting data being presented on quality of life, both from the Vision Horn 141 trial and from the Gaia CLL 13 trial, seeing that the field moves towards this area of toxicity-free, progression-free survival, or quality of life improvement on new targeted agents in CLL. Looking ahead, with all these different treatment options in CLL, I think we need to focus on how to monitor the translation from the clinical trials towards clinical daily practice. So we need to focus even more on how to automatize monitoring of outcome for our patients in clinical practice and develop what I believe is data-driven medicine or data-driven medical art. We need to make sure we do this in a systematic way going ahead.